Good morning. Good morning. Yeah, it's a lovely day when we can join together to celebrate the heritage of our department, OG department, and its origins of CMC Vellore itself. Thank you all for coming here. All those who have taken the trouble to be here, postgraduates, teachers, friends, colleagues, and all those online. We will start with a brief introduction. This was the brainchild of our Directorate in Human Resources Department. Dr. Abby will start with a brief introduction after we start with a prayer by Dr. Rita. I call on Dr. Rita to start with a word of prayer.
Let us bow down in prayer. Our Heavenly Father, we praise you, glorify you, and honor you. Thank you for all the grace that you have showered upon our institution, our department, OG department, on everyone who worked before and currently working. As we spend our time in reflecting on the heritage we have in the department of OG, kindle our hearts with your faithfulness towards our institution and department beyond centuries of years. Encourage each one of us to progress further to fulfill your will for our department. We know we are weak, but be our strength as we progress. Help us to align ourselves to the vision and mission of our institution, lifting high the banner of your name. We humbly ask you to bless our patients, our staff, and students of our department. And today we ask you to bless today's program, all the talks, reflections, future plans, and the discussion. All of this we ask in your precious name. Amen.
Good morning, dear friends, members of the CMC community gathered here today, here in person as well as those who are joining us online. It's my pleasant duty to welcome each one of you to today's special episode of the CMC Heritage Lecture Series. We started this somewhere in the 7th of September 2024 with the Department of General Surgery, and as of date, we have completed 9 lectures or 9 departments. We are here today to witness the 10th in the series presented by the Department of Obstetrics and Gynaecology. The Heritage Lecture series was initiated to celebrate the landmark milestones of a century of the town campus and 125 years of our existence as an institution. Through these lectures, we have been able to trace the origin of some of our departments from their humble beginnings and their growth towards what they are today. As a community, we have been the beneficiaries of the selfless efforts of several heroes and heroines who have helped commence new initiatives and sustain them in the long run. Hopefully, the retelling of our past will help us appreciate them and not just take things for granted. In relation to the heritage lectures, my mind goes to a verse from the Bible in 1 Corinthians chapter 3, verse 6, where Paul talks to the Corinthian church and says, I planted the seed, Apollos watered it, and it was God who gave the increase. Truly, our founders initiated or planted many individuals, both sung and unsung heroes and heroines, watered, and ultimately it was God who honored their labor and gave the increase that we are privileged to see around us today. I'm also happy to announce that these sessions are being recorded and made available on YouTube thanks to the efforts of my colleagues at Telemedicine, Communications, and the Principal's Office. Before I close, I'd like to take this opportunity to welcome our presenters here today, Dr. Jessie Lionel, Dr. Lakshmi Sheshadri, Dr. Vaibhav Londe, and Dr. Lily Varghese. We look forward towards a rich feast. May I now request Dr. Lily, who is the current head of the Department of OG, to come forward and moderate today's meeting. Once again, thank you all for joining us this morning. God bless.
Thank you, Dr. Abby. A warm welcome once more to all our friends, past teachers, and I'd particularly like to thank Dr. Alka Ganesh for taking the time to join us. Welcome, ma'am. So as we go forward, even though we call it 100 years of town campus, it's, as Dr. Abby said, it's 125 years since we started as a medical college. And this heritage, or as we call the legacy, has been the bedrock of our institution. Why did we give this title? Was because it was based on obstetric events and based on what and the happenings of what Dr. Ida Scudder saw in one night, where 3 women died in childbirth with nobody to care for them, that this vision took root. So when we look at it, the result was CMC Velo. What it stands today and where it stands today is not in isolation. It has had long and arduous beginnings, which has often been summarily brushed aside because we just think this place was the way it always stood. The OG Heritage Lecture is for us to look at the past, its people, some of the significant milestones that form the firm ground on which we stand, the very bedrock on which we stand, looking out into the future. Having said that, this program will go through without any announcements in between. And the order of presentations will be by Dr. Jessie Lionel, our past professor and past head of unit, Dr. Lakshmi Sheshadri, our past, the one and only Dr. Lakshmi Sheshadri, our past head of department, and of course, our past professor, Dr. Vaibhav Londe, and me, who both of us are presently working in the department. We will have a conversation with many of our professors who are here today, who will be carrying this department forward when we have completed with the job and we hand over the baton or the torch of life. So that will come at the end. And I hope you enjoy this session. I call on Dr. Jessie Lionel. So we will just come up in series and we will do our presentations. And thank you.
I'm indeed very glad to be here this morning, and I want to thank Lily and her team for inviting me. It's such a blessing to be back, and I'm happy that I'm here. I'll be talking on the foundation of the obstetrics and gynae department. When we say obstetrics and gynae, it was actually the foundation is from the CMC Foundation because Dr. Ida was called to care for women. And I was just thinking, they gave me just 10 minutes and they say cover 60. 1900 to 1960 is what I'm supposed to cover. And they said 10 minutes. I said, okay, I should go as Vande Bharat and finish in time. But then when I was talking to Santosh, he told me, no problem, ma'am. It's better to have a post-mature baby than to have a preterm baby. So I shall take that advice and maybe I'll go on a little longer. Hopefully I want to finish. I don't want to bore you all. I would just say the foundation, when you say foundation, there are two people who have really taken the full brunt or the work of the care for women. That's all of us know, Dr. Ida Scudder, who this picture is familiar to. I don't know, wonder how many of our obstetrics and gynae postgraduates and interns know these two pictures are always in our conference room. We know Dr. Ida Scudder, but I don't know, wonder you will whether you have seen Dr. Carol Jemison. Now, I won't go much into details about Dr. Ida because all of us know. The thing is, we all talk about the three knocks. What came out of the three knocks in her own words is what I want to say. She, at the end of it, she said, I think that was the first time I ever met God face to face, and it seemed that He was calling me into this work. So it's God face to face. And then the biographer writes saying, Dr. Scudder, after wrestling with God about her call and her life's purpose, she decided. And you know what she decided. And so it took almost 10 years before she could come back. The flame kept burning within her as she was trained. And when she came back, she came with such a passion for women. Women, again, this is her own words. Women should have the same access to quality and compassionate healthcare as men, regardless of religion or the ability to pay for it. That was her passion. And how did she go about it? It's her faithfulness to God. Again, she says, I took only one step at a time, the step God wanted me to take. Faithfulness to one call opened the next. Surely that's a heritage for us. And she did come in January 1900 with a great expectation of wanting to work with her father. But God in his wisdom had taken her father away within few months to eternity. And she was left alone, quite sad. But she did not lose hope. And she started her work in a single bedded dispensary in her father's bungalow. And this is how she describes her day. She says, day starts while it's still dark. You know why it's dark? There was no electricity then. They had to wake up in the dark. And she says, I got dressed when it was dark. And that is the kind of work. And she says, comes out early in the morning, dressed, and one after the other, it's rounds, outpatient, laboratory, evening rounds, home visits, emergency call. And she says, reaching home late at night. But what was her? What did she say after that? After all this hard work, a single doctor looking through, she says, I especially give thanks to God for leading me to India to work among these women whom I love and for whom I love to work. That is the heart, the heritage that we are looking at. Yes. And how did she go about it? She did not stay alone. She developed her own support system. She started training nurses and pharmacists to help her out. And she kept systems in place. The rounds and the timings were very correct, record keeping, teamwork, and emotional and spiritual support was given to patients through people who are trained to be with patients. And can you believe there was provision for poor patients? They used to cook behind the ward, both the staff and the students. There's a picture of students working to cook and provide for poor people who don't have food. And the one thing that she had in mind, never turned anyone away for lack of funds. Let's question ourselves here. Let me just, I just want to highlight the kind of obstetric works and their record keeping. This is in the year 1906. You can see they had altogether about 180 obstetric patients who had come to them. If you look at it, about 33% of them got normal delivery. The rest of it is like this. I'm sure you can read: amputation, podal equation, cesarean, high forceps, low forceps, evisceration. You know the kind of obstetrics that they had practiced. Sad, really must have been frustrating for them to come from USA and to be cutting arms and heads and delivering these babies. That was it. And can you believe that they had kept such meticulous record, hands off for their work, really. And because of time factor, I'm not going beyond this for Dr. Ida. I'll just, I'll take this. The next is Dr. Carol Demison, about whom I may take a little time. She is from a place called Corona. I've never heard of it until I saw her in a biography. I thought I know only Corona. Corona in California. And she was trained at Stanford. And she had her fellowship in gastroenterology, gynecology, and radiology in Mayo Clinic. And she was being groomed to become a faculty in Mayo Clinic. And that is when Dr. Ida Scudder, who had gone on fundraising to USA, met her in Mayo Clinic and said, I want you in Vellore. This all she said, I want you in Vellore. And Dr. Carol, having committed her life to a medical mission work, when she heard Dr. Ida call, she did come. You won't believe it. She says on spring 1923, I met Dr. Ida and she called me. By September 1923, she was here. Not September, November 1923, she was here. And she started work at the Mary Tabershell Hospital, that is our Shell Hospital, in November 1923. And there's an uncanny way that Dr. Scudder just pushes people to work. She landed up the next day, she says, go out into the roadside clinic and rounds and surgeries. There is nothing of, jet lag or whatever it is. She has traveled for some 3-4 months in the ship and come, and she was pushed into work. And when she was there, she had met her and told her, see, I'll let you do this and that. But the moment she ended up, there was a need for students. They had started the LMP course in 1918 and they had needed students to be trained. So the moment she comes, she says, oh, Dr. Carroll, I'm going to put you in charge of tropical clinical pathology department, which has never done any pathology slides. And she had to start doing prepare medium and how to look at microscope, and physiology department, and also in charge of teaching students. And this is again, she landed up in mid-November. Mid-December, Dr. Ida and her friends, 3 more medical people, decided to go on 2 weeks holidays, leaving Dr. Carroll alone in the hospital. And she couldn't say anything because she was so much higher, and she said she had such a charisma we could never say anything to Dr. Haida Skada. So then let's see about what happens in those days. The first delivery. Let's look at the first delivery. One day while she was on her roadside clinic, she was stopped by the villagers on the way, asking the doctor Amma to come down and conduct a delivery. She said, conduct a delivery on the roadside. And there, much to her amazement, there was a donkey in labor with the hind feet coming out. And she said, no, I don't know. But then she was new to the place and she had no courage to say no to the villagers who were standing there. So she says, I went there, I pushed and pulled and pulled. And one last time, can you believe that first delivery she did was a breech delivery on a donkey? And the donkey was well, and the villagers were so impressed with her. But what Carol decided is, I have come here to take care of humankind, not animal kind. No more of this. So that's her decision. Then the first blood transfusion. Within those 2 weeks, there was a patient who came with vesicular mole, and she has bled so much, and she was so pale, and Dr. Carroll felt that she definitely needs blood. Until then, there was no blood transfusion at all in the hospital, in this hospital. And she said, how could I get a donor? What could I do? Finally, she said, I'm a universal donor. I will give my blood. And she called the intern, the LMP intern, licensed medical practitioner intern, and said, put a cannula and take blood from me for donation. This poor, frightened intern must have been scared to put a needle on her white skin. She poked and poked and poked, and she couldn't get. Finally, you know what she told her? Do a cut down on me and take blood. And she asked her to cut the skin and take a cut down, put a cut down so that she can get a cannula in, get the blood, and transfuse the blood for that patient. And she says, I went exhausted late at home. Can you believe in the middle of the night, there is an uproar in front of her room, all relatives shouting. Do you want to know why? I don't have time to tell you. If any of you are interested in reading books, please read books. I want to tell in this time, many young people are there. It's such a blessing to read books. Just don't stop reading your social media. Please read books. And any of you want to get interested, please read the book and find out what happened. I'll tell you the patient was fine, but the ruckus, you find out why it was. All right. The third one is then within few days, within the 2 weeks, a patient comes with a ruptured ectopic. Big hemoperitoneum patient is going into shock, and she said, I will somehow palm them off, send them off to another hospital. She's pleading with them. It's a Muslim patient. They said, you please take. They said, no, we will stay here only. And she said she will die. So she has to operate. There's no blood. Then suddenly she realized, get a cup sterilized. She asked someone to get a cup sterilized. And she opened the abdomen, quickly clamped the bleeding site, took the sterile cup, took out the blood, and strained it through the gauze and got the blood. And she transfused the patient, and patient went well home. And what happened at the end of it, she says, I had come through the valley and I had found that my Lord had always been with me. And that increased my faith and confidence. And that is where it is. Again, a heritage, walking alone, but God walking with us. That's the heritage that we see. And some more interesting and amazing stories. Can you believe they had worked with very limited resources? And rubber gloves in summer used to get disintegrated. Dr. Carroll says at one time, Dr. Carroll and Dr. Ida did a cesarean section with bare hands. Can you believe that? And obstructed labor. Sure enough, in those days, as we saw decapitation and everything, patient comes from a local guy to an Indian doctor and then to a clinic and finally landing up here. And this is where actually Dr. Carroll learned a lot of new obstetrics coming to India. So she did what we call as pubiotomy. She says what we call a symphysiotomy to enlarge the birth canal. And she said the baby and the mother were well. And again, a repeated abortion. And Dr. Carroll diagnosed cervical incompetence, and she didn't know what to put. This is her word. So I embedded my drawstring in the cervix to keep it closed. She took her drawstring and she kept it closed, and she said the patient went on to term and deliver well. Then the last other thing, interesting, I have lots to tell you, but I won't take much time. 3 abortions at 4 to 5 months. she was absolutely sure it's because of a congenital abnormality. And she, having had some experience in radiology, she did an X-ray and found out it is a uterus didelphus or double uterus. And she told this patient, see, I can do a surgery, but I'm not sure whether you would conceive. And if you conceive, you'll have to have a section. The patient was willing. She said, do what you want because I've already lost 3. And she did the surgery and she told the patient, when you conceive and when you're term, please stay close to a hospital so that we can do a section. This patient was lost. She went off actually to the, if you read the story, you will know who I'm talking about. She went to another country. And at term, she went into labor. By the time she went to the hospital, she was ready to deliver vaginally. She delivered a healthy, normal boy baby. After that, she had 2 more normal deliveries. This is the work of God done through people who could commit themselves to God. And not only in obstetrics, they also did a lot of gynec work, especially VVF interest for Dr. Lily and team. And Dr. Carol had never seen a VVF repair in America. But Dr. Ida here had developed her own technique, and Dr. Carol learned from it, and their center became a referral center for VVF. I'm sorry, I had a URI and my throat is getting dry. Infertility. RMU people, there was infertility then itself. And then how she tried to do, she whatever, and she had done an artificial insemination, and the baby was born on Dr. Carol's birthday. You know what they named the baby? I'm sure you can guess. Okay, so this went like this 6 years from 1923 to 1929. Then she went for a short furlough, and she came back in 1929, where she was made the head. 6 years she took to become the head. And once she came back, along with obstetrics and gynae, they had so much interest in teaching patients, and they said they went out of the way to teach patients. And their biography says makeshift mannequins were done from cast-off tires to teach obstetrics, and they called a local potter to come and make a life-size pelvic mannequin in clay with the tubing so that they could teach obstetrics for our students. And not only that, she was very particular that students should be trained in surgical techniques. And she said, I gave them opportunities every time, but I was close to oversee them. That's something that which we have to ask ourselves what's happening. And also, they had connection with many places, many meetings and conferences they have attended. I don't have time to write all those places, but once they had the Madras State Obstetrical and Gynaecological Society conference was held in Vellore. Now, I think I'll go into a bit of photographs. This is Dr. Carol with OG team in her early days when she came. And this is Carol with the interns. You can see the number has increased, and Dr. Carol, from her dress, she has gone into a sari. That's the change that has come in. And it's really amazing how people had stayed on for so long and worked. So we have a rich heritage. So what do we do with the heritage? Do we inherit the heritage? There's a heritage. Do we inherit is the question. I just want to leave with 3 slides. One is heritage to inheritance. What is the personal inheritance that we can take? A deep commitment to God that we see in them, God's leading, and our faithfulness to God. They were constrained by the love of God for women and for we as to all our patients. And teamwork was something which was so much there. Everybody pitched in whenever there is a time where there's a need. And hard work, nobody complained about long hours and kept on. I'm sorry about work-life balance. I'm old school. I leave it. So hard work, kept timing, protocols. That was something which we should learn. And innovation. When you don't have something, rather than cribbing, innovate. And in difficult times, always, and difficult times, let's remember that we are sustained by God. This is personal. And as a department, what do we inherit? Up to date with the subject. They were. And teaching and training students was so important to them. And giving chances for surgery to the students. And meticulous record keeping from the time she started, there has been meticulous record keeping, teamwork, as we said, and connecting with others. We can't be in our own little areas. We should be able to connect with others in meetings and conferences, which we are doing and we will continue to do. The last but the least, but treating the poor, regardless of religion or ability to pay, never turn a patient away because they cannot pay, is something which is left by them and for us to take it up. And the last thing that I'll say, heritage to inheritance for our institution. This, our institution, is founded on the Lord Jesus Christ, His truth and compassion. So as long as we remain in Him, in His truth and His compassion, we will be blessed and we will be a blessing to people and nations. And I'll end here. May the Lord continue to bless us that we will be a blessing to many.
Good morning, and my privilege. My privilege to be here today. Good morning to all of you. I think it's only appropriate that I start with a picture of Dr. Ida Scudder, because to us obstetricians, Dr. Ida Scudder means obstetrics and the Department of Obstetrics and Gynecology. What's more, the term Christian Medical CMC Vellore also means obstetrics and gynecology to us, because in response to the story you all know, the 3 knocks, Dr. Scudder started this hospital. It was a hospital started by a woman for women to attend to the obstetric needs and of course the other health needs of women. And therefore history of the departments of obstetrics and gynecology is history of CMC Vellore, which begins with Dr. Ida Scudder. And we all know that, therefore, the Department of ONG began in 1900 when Dr. Scudder had her roadside clinic, and we all know about the bullock cart and the delivery conducted there. And of course, subsequently moved on to the single-bedded nursing home on Arni Road, where again, obstetrics care was provided for various women. Women came from as far as 50 miles in and around Vellore because they had by then heard of this place and they knew about the obstetric care provided here. In 2 years' time, by 1902, we moved to the Mary Tabor Shell Hospital, which had 40 beds. This is a current Shell Hospital in its form at that time. And the first major surgery in the history of CMC Vellore was a hysterectomy, which was actually performed in this hospital by Dr. Ida Scudder with the help of a nurse. So the initial years between 1918 and 1942, we had Dr. Scudder and others. The training of nurses and midwives in obstetric care began in 1909. Licentiate program in medicine began in 1918, and they moved to the main hospital, that is the town campus, or this one, in 1924. During these years, as Dr. Jesse pointed out, we had the eminent, the most important, eminent, dedicated, all-rounder women, leaders who are inspired by Dr. Ida Scudder. Dr. Grimson's name is mentioned, Dr. Carol Jemison, we just talked about, and Dr. Ida B. Scudder. And remember, none of them had a specialized degree in obstetrics and gynecology, but they all served as obstetricians. In fact, Dr. Ida B. Scudder was a trained as a radiologist, but then they all rose to the occasion and they all served. And you just heard the story of Dr. Carol Jemison. So now I move on to the years between 1942 and 70s. 1942 is important because that's when the undergraduate course was started in CMC Vellore, and the first batch of students were admitted. And therefore, for the formal department of obstetrics and gynecology to meet the university needs was started at that time. And the people in the department at that time were Dr. Miriam Manuel, supposedly a very, very diminutive figure. Heard lots of stories about her, and Dr. Epen. Both of them had an MBBS degree. In a year's time, in 1943, Dr. Carol Jemison returned with an FRCS degree. Remember, many of these women who had joined here and had no specialized degree were sent to acquire the training and qualification one by one overseas by Dr. Scudder. So Dr. Carol Jemison returned with an FRCS. Then in 47, Dr. Hilda Lazarus joined as professor of obstetrics and gynecology and the principal she was at that time. The Department of OG was divided into two units in the 1950s, and Dr. Paranjoti and Dr. Miriam Manuel were the two heads of the two units. Dr. Carol Jemison continued to work in the department. The department was divided into three units later, which is what it was when we all joined, even in late 1970s. This was the then the town campus, and we were here from the beginning. We have been in this part of the hospital. Now, in the subsequent years, we had other eminent teachers. Till 1973-74, we had Dr. Vimala Isaac, Dr. Prabhavati Kundas, Dr. Helen Hemalata, Dr. Indra Randhava, and Dr. Munshi. I'm sure many of those who've been here those years have heard of these names. I've only heard of them. I do not know any of them personally. We also had Dr. Tom Barnes from WHO, who visited during those years and subsequently came later, and we all had the good fortune of working with him. The postgraduate courses started here. So the DGO started in 58 and MD started in 1975. Dr. Paranjoti, Dr. Manuel, Vimala, Kundas, Dr. Randhava, all were extremely good surgeons. And their focus was on building and establishing a department with good obstetric services and training of students so that they can handle complicated problems in mission hospitals, because that was the basic goal and idea at that time, that women should be trained and sent back to mission hospitals to provide obstetric service. There were regular ward rounds, journal clubs, and teaching sessions. Dr. Paranjoti was the first to start treatment of choriocarcinoma methotrexate in India. Strict discipline was the mantra those days. All of them led by example, always available to the trainees for guidance and support, and they left nothing to chance. Very intuitive at diagnosis because they did not have the CTs, MRIs, or even the ultrasound scans. So clinical acumen is what they depended on, which was exemplary. There was a professionalism and accountability in the department, which was impressed upon the postgraduates and interns. Perinatal audits were regular and meaningful. The hands-on training in OBGYN stood the PGs in good stead, even when they went overseas to work. And the students were taught to be innovative and manage challenges. You must be wondering where I got all this information from. I have not worked with any of them, not even met them. I happened to contact a lot of people. Professor Alice Kurula, who did her undergraduate at them, Dr. Alka Ganesh, her sister, Dr. Naina, who did her PG here in their department during those years, Dr. Meera Kishan, and all of them were extremely enthusiastic and happy to share their experience and their views, and of course their comments about the department at that time. There was a lot more information that I got from them, a lot of insight that I got, but I really don't have the time to share everything. And I thank all of them for this. The 1970s and beyond till 2000, Dr. Vimla Isaac, Dr. Indra, and Dr. Helen Hemalata left after the turbulent years in CMC, which I'm sure many of you have heard about. The department was then taken over by Dr. Charles, Dr. Bala Subramaniam, and Dr. Prabha Jairaj, and later by Dr. Padmini Jasper. The Vellore Robson Gynae Society was formed, and the annual Ida Scudder oration was initiated by Dr. Charles in 77, which is the year I joined for my postgraduate, and I still remember the inspiring oration by Dr. Miriam Manuel. The subsequent orations have been delivered by Dr. Krishna Menon, Dr. Bhaskar Rao, Dr. P.K. Devi, all big names during that time, Dr. Barnes and Professor Edwards of IVF fame. They all have been here to deliver the oration. And the landmark event actually brought together all the obstetricians from the government hospitals, the private practitioners, and the CMC OG department. And therefore, I think it really did serve a very, very important purpose, because otherwise CMC always stood aside and apart. This brought us all together, and it was a great event every year. Dr. Prabha Jairaj, who took over OG Unit 2, ran a tight ship. Her teaching during grand rounds is legendary. I happened to take over the department after her. Skilled obstetrician who delivered all the staff children in the campus, and she led by example, was available anytime to help all of us. Under her leadership, OG Unit 2 had regular teaching sessions, paper reading, journal club, and teaching rounds. And the morning reporting system from labor room was introduced by Dr. Prabha. All of us were woken up at 5:30 in the morning and informed about whatever happened through the night. And of course, this was like a morning alarm system after which we could all get up and go for our rounds. I think somewhere along the line it has been scrapped, but I must tell you it was a good system because when you came in the hospital morning, you knew what had happened in the night, and it really was very helpful. Dr. Bala Subramaniam, fondly known as Dr. Bala, was a great teacher and a skilled surgeon, and those who have worked with him can never forget him. Such an easygoing, happy man, and a pleasure to work with. Would be the first to read any journal that arrived in the department or in the Dodd library and enjoying discussing the updates with postgraduates. You should see the gleam in his eyes when he comes the next day and asks you a question, and the answer is actually given in the journal, which is with him. And he knew that none of us actually knew the answer, but the pleasure he took, and we all knew it and understood it, and we played along. Those were the lovely days. A friend, philosopher, and guide to many. During this period, Dr. George Kurla returned from Adelaide and put together the reproductive medicine unit, 1995. Other faculty who joined him were Dr. Susan George and Dr. Christina James Irwin now. Working pattern in the labor room changed during that period. Before that there were common registrars. No, there were individual registrars from independent individual units in the labor room at that time, and they managed the particular unit patients. But this common registrars in the labor room for all three units, this system and the 12-hour shift was introduced during that time. Dr. Padmini Jasper was known for her involvement with each registrar and took personal care, counseled and mentored each of them. Very well known obstetrician gynecologist and a dedicated one at that. The unit took special interest in HIV positive women under the leadership of Dr. Jesse at that time. The involvement in research began during this period. There were many multinational trials that the department was part of. MaxSelf trial, the Term Breach trial, the Magpie trial, the Pearl trial, and a few WHO trials as well. There were special areas of interest and clinical research. There was one unit which was focusing on cervical intraepithelial neoplasia, cervical and cancer, and another unit focusing on fetal growth, variations in length of gestation in different countries, etc. There were several publications during that time. All of them actually resulted from the studies conducted here in the department, and actually they all served to they helped us to change the protocols in labor room rather than depend on or go by guidelines published by other countries. These studies were the ones which we used to actually, when do we induce your postterm? We didn't want to wait for 42 weeks, and it was following a study that we decided we will induce them by 40 plus 3 or whatever. So there were a lot of protocols that were developed subsequently. Perinatal mortality and morbidity audits were very regularly conducted every month, and they did serve as teaching and learning sessions and led to fruitful interaction between neonatology department and ours. And again, several new protocols, the labor room were born out of this. Gynae oncology clinic was started in the year 1998, along with the radiation oncology. This later included the medical oncology, and subsequently tumor board meetings were introduced. And of course, now it's been taken over by the Gynae onc unit and has metamorphosed. First, laparoscopic sterilization was basically laparoscopic sterilization started in 1980 when Dr. William Petty visited us. I wouldn't say it was the first one because I know that Dr. Charles had performed a few before that. He had one of those huge mammoth-looking laparoscopes. I still remember the instrument. After a few attempts at that, I think he also gave up, and then we reintroduced laparoscopic surgery. We all trained under Dr. William Petty. First ultrasonography machine was bought by OG department in 1985. Dr. Alice George had just moved from radiology to OG, and she was a great help at that time. And all of us learned doing obstetric ultrasound just by using the machine because none of us really had formal training. First CTG machine was bought in 1985, and it was only used for NSTs. Colposcope was acquired in 1985, and first IVF was performed in 1996. What were the infrastructure modifications? Infrastructure in the 1980s was that the K labor room was extended, K private ward was constructed, OG offices were expanded, and L ward was added. You may wonder where all this were. So just to tell you, just to give you an idea, this is a present one. We were here again. This was the L ward, which was added much later. This is the first floor is where the labor room was. K private ward was here, and the K ward was also on this floor. And here the ground floor was the OG offices, J ward, and J labor room, where the cardiac intensive care unit was subsequently. This is just for the sake of those who have not been here during those years. During a visit by the then director one day, I in fact went on rounds with him. I remember it was realized that the obs and gynae wards were in very poor shape. I don't think the administrator had ever come to our department by then and looked at the state of the wards. And when they realized that it was so bad and that the place needed renovation and there was space crunch, the seed for the Ida Scudder centenary block was sown. Hours and weeks of planning, fundraising, and efforts by the department and the administration finally culminated in the inauguration of the centenary block in 2000, and the department moved there immediately after. This is where we are now. I hand over to Vaibhav. Thank you.
Good morning, everyone. Thank you for the privilege of speaking to you on behalf of the Department of Obstetrics and Gynaecology. I have some really big shoes to follow in. And in fact, while I was preparing for this talk, it brought back memories of paper readings in OG2, because I was an OG2 boy. I did my internship there, I did my non-PG there, and I finished my final year there. And when Dr. Lakshmi was asking, did you finish your PowerPoint, send it over, my heart rate started going up. I think Dr. Lakshmi has kind of underplayed the part which she played in the development of the department, because if I'm not mistaken, she was the chairman of the committee which took up the challenge of building them. And one of the comments which she made when she was building, you won't believe how many toilets there are in this building. I don't know whether you remember this comment, but she said there are so many toilets. Now we find it difficult. So that what I have titled my topic is Y2K and beyond. And for the generation Z and beyond, the year 2000 was very significant, because in the early days of computing, the years were written as in 2 digits, the last 2 digits of the years. And there was this worry that when the year 2000 comes around, the computers won't know how to calculate the date, because it won't be 2000, it will be 00. So they won't know whether it's 1800, 1900 or 3000. Fortunately, the end of the world didn't happen. In fact, it was a time of opportunity and expansion for OG. And we shifted to the new building, which of course came with its own set of problems. It was akin to the shift to Ranipet, which has happened recently, but on a less larger scale. We don't know how the patients were going to be posted, where we would go. But one big advantage of shifting into this building was the theater was next door. Now, I don't know how many of you know that the main theater is where we used to do our emergency cesarean sections. And if there was a cord prolapse, one PG would get onto the trolley, put the hand inside and push the head up, and a certain part of their anatomy would be quite elevated. 2 people would pull and push the trolley all the way from the labor room, which was on the first floor, through the lift, down to the ground floor, and then go to the main theater. So these all stopped when we moved into the new building. But like I said, there were always teething problems, there were issues, but we have come out of that. Now in 2002, Dr. Lakshmi Sheshadri took over the Department of Obstetrics and Gynaecology as the head. And she was supported by Dr. Mathai Matthews, and Dr. Lakshmi obviously was the head of unit of OG2, and Dr. Padmini Jasper. We had 3 MD seats and 6 DGO seats. I looked up the statistics for 2000. We did 7,000 deliveries, and the LSCS rate at that time was 20%. We shifted to the new building. We opened the gynecology oncology clinic and the menopause clinic, and we started venturing into minimally invasive surgery, started to do LAVH, hysteroscopy came in, and there was a lot of new equipment which came into the labor room at that time: fetal monitors, ultrasound machine, pulse oximeters, which were all helpful for the monitoring of the semi-ICU patients. At this point of time, we also noticed that there was a shift from more clinical monitoring where you would put the hand on the patient's abdomen to check the contraction, and you would check the fetal heart with the stethoscope, to actually being dependent totally on the CTG. And this is one of the changes which has happened over the years. 2004 to 2005, we had a brief interregnum when Dr. Mathai took over the mantle of leadership in OG. And it was notable that during this time, we had the first discussion on subspecialization within the department. It didn't work out, but this was the first time that the idea of obstetrics and gynecology splitting into the various subspecialties came up. 2005 to 2009, Dr. Aruna Kekere took up the mantleship of leadership, and she was supported by Dr. Alice George, Dr. Padmini Jasper, and Dr. Annie Reggie. This era saw the establishment of the Urogynecology Clinic, which eventually evolved into the current OG2. There was a growing focus on research, academic excellence, and evidence-based patient care. We had a lot of exposure, not only nationally, but internationally, and the IMAC program started, which ran until about 2011. We started doing advanced laparoscopy and many perinatal procedures. 2008 to 2012, Dr. Alice George was the head of the department, and she was supported by Dr. Aruna Kekere and Dr. Annie Reggie. In 2010, we had the great divide when we expanded into 5 units. Dr. Lakshmi Sheshadri took over the unit 1, which was focusing on oncology. Dr. Aruna Kekere focused on, and her team focused on urogynecology. OG3 was a little weird unit in that they had both obstetrics and gynecology. They refused to let go of obstetrics and gynecology, but it was appreciated by some people, not so much by others. But anyway, Dr. Ruby Jose took over as head of OG4, and Dr. Gigi Matthew headed OG5. I remember that at this point of time, there was quite a shortage in the unit because we were unable to get people into place before we split. So all the people who have come into the unit have come after that. And gradually we have now come back to a normal situation. We increased the seats from 3 to 6 during this time. So I think in 1975, when we started the MD, until 2000 and somewhere in this 2010, we had only 3 seats. Now we've split into 5 units, and we still have only 9 registrars per year, with the DGO being only 2 years and the MDs being 2 years, because all of our MDs in those years were post DGOs. We did not have a straight MD, meaning we usually didn't have a straight MD. 2013 to 2015 saw Dr. Abiram PDKL get into the hot seat as he took over the Department of Obstetrics and Gynecology. He was supported again by Dr. Jessie Lionel, Dr. Aruna Kekere, Dr. Annie Reggie, and Dr. Ruby Jose and Dr. Manisha, and Dr. Gigi Matthew. This era was important because it saw the formation of the Department of Gynecological Oncology, which was the first department which was distinct from obstetrics and gynecology. Reproductive medicine was still going on, but it was functioning as a separate department, but did not have the designation of a department as yet. And this, we saw the increase in MD seats to 11 between 2013 to 2014. Dr. Annie Reggie took over in 2016, and the heads of departments at that time were Dr. Jessie Lionel, Dr. Aruna Kekere, followed by Dr. Lily. Dr. Annie Reggie obviously was heading OG3, and Dr. Manisha. By this time, we had split into pure obstetrics, pure gynecology, with gyne-oncology being taken care of by the Department of Gyne-Oncology. This is the only picture I put up because this is the last batch of DGOs. And we saw, in lieu of the DGOs base seats being taken away from us, we got another 6 seats in the MDs, which led to the current strength of 17 postgraduates. Dr. Gigi Matthews then took over the headship of the department, and she was supported by Dr. Elsie, Dr. Beena, Dr. Lily Verghese, Dr. Annie Regine, Dr. Anuja, Dr. Manisha, Dr. Rita, and Dr. Swati, and Dr. Gigi in the various units. This era was notable for the fact that we had the renovation of the labor room, which was long pending. For 19 years, we had been using this labor room, and it had become quite dilapidated, and we needed to change it. Also, we had the establishment of the fetal medicine unit. At this point of time, we had a very strong emphasis on liaison and ties with the mission hospital, where our postgraduates would be sent for about a month to various mission hospitals. And it was from both sides, both the mission hospital and the postgraduates benefited greatly from this exchange of personnel. We had an emphasis on efficient care without compromising quality. And this was the era when we saw some of the highest numbers in both labor room and in OPD. 2023 to the present, Dr. Lily Verkis is our current head, and she is supported by Dr. Beena. Dr. Lily obviously is the head of Unit 2. Dr. Annie Reggie, Dr. Anuja, and Dr. Kavita in turn have been heads of OG3. Dr. Swati and Dr. Rita have taken care of OG4. And Dr. Gigi and Dr. Santosh have been the heads of OG5. During this time, we have shifted to the new gynecology OPD building and finally leaving up space in the current obstetrics OPD for it to expand. We have had to realign our functioning of the department to the needs of the students, both in terms of postgraduates and undergraduates. Now, this has been a result of the end of the DGO course, which means we don't have postgraduates at the MD level coming to us with basic skills in place. When they come as MD first years, they don't have that 2 or 3 years of experience which we used to have. Also, we don't have non-PGs in our department. I did a non-PG. Many of my colleagues have done a non-PG, and then we only joined the department. So by the time we actually joined our post-graduation, we had a fairly strong basis of what to do. Now, the training for postgraduate starts from scratch. And also with the current examination system, there is an emphasis on getting into the course and then learning to work rather than trying to do both of them simultaneously. And we are still in the process of evolving and improving our curriculum to respond to the situation. What is the current scenario? Obstetrics, in the last year, we dealt with over 1 lakh OPD patients. We had over 10,000 deliveries. There's an increasing complexity of cases. High risk is not only previous LSCS. It's not just a diabetic. It's not just a hypertensive. Now they have Takayasu's arthritis. They've got a mitral valve, double valve replacement on warfarin, and they've got IUGR, and they've got something else. The complexity of the cases has gone beyond what it was during our training time. Dealing with patient expectations. Gone are the days when patients used to say, you do whatever is necessary. Now they question you. They ask you, why are you doing this? What is the outcome? And it has become increasingly difficult to deal with patient expectations. Overall, in obstetrics and gynecology, we had near about 2 lakh patients in the OPD last year. Gynecology, we have over 60,000 OPD patients, over 4,000 OPD procedures. We had more than 1,000 gynecological procedures, out of which 58% are laparoscopic, which is very, very different from when I did my post-graduation. We do advanced laparoscopic surgeries, total laparoscopic hysterectomies, myomectomies being the prominent ones. Under the pelvic reconstructive surgeries, they're doing laparoscopic vaginal and open vesicovaginal fistula. They're doing vaginal reconstructive surgeries such as Davidoff's, pubovaginal slings, and Singapore flaps. We have come a long way. Postgraduates, like we said, we have 17, which obviously has resulted in 17 theses being in the department. And therefore, our research output has by default increased. In spite of that, there is a lot of independent research going on, which was one of Dr. Gigi's focus when she was the head of the unit. And these are some of the articles which we have published in the last year. I would be amiss if I did not mention our offspring, for lack of a better term. Gynaecology was established on the 8th of July 2015. They started their MSH in 2016. They ventured into robotic surgery in 2022. Their seats initially, which started with 2, have increased to 3 in 2023. They have a very protocol-based management of gynecological cancers. They have a multidisciplinary team, and they have comprehensive oncological procedures, including HIPEC, laparoscopy, sentinel lymph node biopsy, ERAS, and robotics. Reproductive medicine, like has been mentioned by Dr. Lakshmi, was established in 1995. The first IVF patient delivered in 1996. The first gift happened also in 1996. 2002, laser hatching was introduced. Blastocyst vitrification, low-cost IVF, and the first micro TSA baby followed in quick succession. They had an FNB in reproductive medicine, which was the first in the nation. 2006, They had the postdoctoral fellowship program in reproductive medicine. 2008 saw the establishment of the postgraduate program, which was the AHS program. 2019, they became a department with, the department was a little bit before that, but in 2019, their MCH program started with 3 candidates. And one of the notable things for this department is that they have a very strong focus on research, and they have collaborations with ICMR, WHO, and the Department of Health and Health Research under the Ministry of Health and Family Welfare. Fetal medicine unit was established in 2022. This was a long felt need in our department. August 2024, they opened their postdoctoral fellowship. 24 to 2025, they have had over 7,000 OPD patients. They've done over 400 prenatal invasive procedures, which includes chorionic villus sampling, amniocentesis, and chordocentesis. Going back to the future, always we hear from our seniors we had it tougher. But I think that not having gone through postgraduate in our time when they have e-journals, they have to do all sorts of things, including CME credit points, it is difficult for us to appreciate the stresses and the pressures which the current postgraduates are under. You might think that what Dr. Aida did, and no doubt it was amazing, but for a person of that age of that era to understand what the postgraduates of our era go through, it is totally different, and what the pressures they have currently is totally different. I think that as seniors we have to stop saying these things, this was the way it was in our day, this was the way. We're not going to go back to that. So we have to adjust to a new reality, and rather than the children adjusting to us, we have to adjust to the way they are. Having said that, I think it is important for us to remember that we always stand on the shoulders who have come before us. My teachers are here in the front row, Dr. Lakshmi Sheshadri, Dr. Aruna Kekre, Dr. Alka, who I still remember finished me off when I went for my peripheral posting, because I did not tell her that a diabetic patient with Fournier's gangrene has got Fournier's gangrene. And she's admitted in the hospital because the male is admitted in the hospital because of Fournier's gangrene. So I said, it's because of sugar control. Yeah, but you don't realize he's got Fournier's gangrene. She doesn't remember it. I do. This was in the old place. The future is really bright and beautiful, and I fully expect the future generation to outshine us and do us proud. Thank you so much.
That was a lovely series of lectures. So we really understood the history on which our department stands. It's been a wonderful journey. And now, as we start, we are going to go away from the period of dates and developments. We are just going to look at what the future holds. So this was where we all started. We looked at the silver and the gray building, rather the gray and the blue building. And we hope to have a vision for the future, and we hope our younger generations are enthused and take it way beyond where we stand today. Hard skills, reams have been written about hard skills, about training, about management. These things are things we do not need to go about. In fact, you pick up any journal, you will get all these things there. Rather, very often what we overlook is the problems that we face, and these are the problems that very often stretch us to our limits and bring us down on our knees. So these are the what we require very often is soft skills. And I always liken our department to a bus where somebody is trying to drive the bus, but all the kids are putting their hand and trying to jump out of the windows one by one. So it's very difficult to keep everybody moving in the same direction, enjoying their ride, and having that same vision that you're going on a lovely trip. So let's move on this trip. This is what we require, soft skills. And we hope that some of you do not just come here to pick up hard skills, but it is the soft skills we also want you to be endowed with. So having said that, I said, what better place to start than our vision statement? Okay, and this is where we go back to time and again to find our roots and to move forward. So I will be taking what this vision means. So the Christian Medical College Vellore seeks to be a witness to the healing ministry of Christ through excellence in education, service, and research. What does it mean to be a witness? A witness is somebody who sees things firsthand or has a lived experience. So I will take you to what it means to be through the healing ministry of Christ in few brief slides. First and foremost, we as the Department of Obstetric and Gynecology hold an immense value for life. We are where we start caring for a woman where life makes a beginning in reproductive medicine unit at the very, very beginning, of course. And we take them from the womb right down to the tomb. An immense value for women's life, an immense value for human life. And yes, we are pro life. For we believe that God created us in our inmost being and we are knit together in our mother's womb. And that life has immense value. So, the other principle we stand by on a daily basis, irrespective of caste, color, creed, language, we have given reductions. We have treated patients to our utmost best. We have all put our hands to the plow and we have not given up until we have got the best possible result. So that means it's a very foundational principle of our department, the equality and the empathy with which we treat patients. We do not treat one different from the other irrespective of their financial or social class. And I want the future department to remember that we treat those in need with the same care and respect and the compassion we wish for ourselves. That is something I hope we always remember at the bottom of our hearts. This respect also extends to our colleagues, where we treat one another with honor and with respect, understanding that each one has something to contribute and to add to the system. The other thing is what I really appreciate about CMC is our incentive free treatment. None of us are given an extra incentive to treat somebody, but we work as hard for the general patients as for the private patients. We have various programs which help us to treat the poorer patients, like the person to person fund, which helps to give subsidized treatment, free drugs, hospital free slots, the 1 lakh, 1.5, 2 lakhs, in fact, even up to 5 lakhs. We treat the rich and poor alike with the same quality of drugs and treatment. And so this is something which is a very, very foundational principle again. Whatever we do, this is something, there is a board in CBOR Theatre 4 saying, whatever you do, work at it with all your heart as working for the Lord, not for men. What does it mean? It calls us to integrity, to work our hardest and our best when nobody is watching us. And this is what I would like the future generations to take back. As in Dr. Ida Scudder's words, do not live planning great things for tomorrow, dreaming of a great future. Have the highest ambition and let that be of doing good and doing each day's work well. For you have today in our hands. We do not know if we have tomorrow in our hands. The very important thing is teamwork. We should always remember that we never walk alone, that we are always walking with somebody else, and that we should walk in agreement. The leader is dependent on the team, and the team is dependent on the leader for a vision. And they both should align for us to move forward. Okay, about training, lots has been said, lot has been written. I am not going down this rabbit hole. Of course, our college incorporates various advances, whether it's on the digital health, electronic records. We insist on it, which causes a lot of heartburn for many people. But of course, like Dr. Vaibhav said, we all have our teething problems and we hope to move forward. International collaborations, exchange programs already taking place at the undergraduate level. And we can promise that we will be adaptable to future training challenges in a rapidly evolving landscape. Now, I call upon all the senior professors of our department to please come up on stage because to discuss a few, Dr. Gigi, Dr. Anne, Dr. Kavita, Dr. Manisha, Preeti, Dr. Rita, and Dr. Santosh. We will be discussing few of the soft challenges that we face, none of those hard challenges, because we have had we want to retain those figures and those things that we have heard from our previous speakers. So just let's end it on a lighter note. Okay, Dr. Gigi. So this was the second part of our vision statement about excellence in research and teaching. So we know that ongoing learning is by active research engagement and it is at the core of future patient care. So the three questions I put up was, how do we foster motivation and critical thinking? How do we promote an evidence-based mindset in clinical practice, and what initiatives are being taken to encourage our students?
Thank you, Lily. Basically, our vision is excellence in clinical work, education, and research. But you will agree with me that research should actually drive both clinical work and education. Historically, we as a department has made an impact only with large being participating in multicentric studies, and we have made a major impact. From 2007 to 2015, we were part of a large coroner's trial where we dialogued with premier institutions all over the world, and they were amazed at the caliber and potential our department has. I don't think the giants whose shoulders we are all standing on, some of the giants are here today. They didn't realize that we have a department that is world standard. And a lot of us don't realize that. So we need to continue to engage. I've always thought that less than 5% of our postgraduates actually go on to do good research that make an impact on clinical work in India. And therefore, we should engage with our middle level staff. We should engage with middle level staff who decided to stay on in CMC, and they should be not just encouraged, forced to be part of systematic reviews and find gaps in the knowledge that is required to make world standard guidelines for our own country. So far, we are always depending on NICE guidelines, American guidelines, WHO guidelines, all of which we know have several shortcomings. And therefore, we should pioneer working on systematic review, find gaps in our knowledge, and use those gaps as research, clinical equipoise, and continue to do good research. Encouraging undergraduate and postgraduate, we have a very good system because you have to be passionate to do research. Time is finite and resources are finite. We should encourage undergraduate and postgraduate who have a passion for research that we are already doing, and we should continue. But our emphasis should be on the middle level staff who continue, who are confirmed, who stay here. We should take it to greater heights and engage with Indian Council of Medical Research. Even though it's very difficult, we should persist. Engage with Indian Council of Medical Research. Thank you.
Thank you, Dr. Gigi. So to Dr. Preeti, the field of bioethics is a seething area. You know, it's moving, it's constantly evolving in a relativistic world. Many of us do have a sense of right and wrong. What is the basis of our principles? And many of our intuitions are often misleading. So the questions to Dr. Preeti are: why is bioethics important? How do we train our students to apply it? How does bioethics as a discipline also help us to avoid medico-legal issues?
Thank you, ma'am. Thank you, ma'am. Bioethics is very crucial in obstetrics and gynecology as we deal with the daily practice of our obstetrics and gynecology. As we know, obstetrics deals with two lives, and there can be sometimes conflict between the maternal right and the fetal right. And there can be situations in gynecological practice where we do intimate examinations, sensitive examinations of the mother patients. And in this point of time, the bioethics plays a major role where we take informed consent, and that helps the patient to maintain dignity, autonomy over their body testing. And this can also help the provider to make decisions during their complex situations where we face social issues or legal issues. And overall, bioethics helps the provider and the patient to come to a conclusion or in a clinical dilemma. And how do we train our students? This is very important. As teachers, we have an important responsibility that we train our students in bioethics. This is not something that can be learned as a one-day module, but this has to be integrated into our curriculum. And from the early part of their obstetric training and the gynecological training, where the students are taught to handle situations in real life scenarios We can give them case-based scenarios where there is a dilemma. It could be examples where the fetus has a non-reassuring fetal status requiring an immediate delivery while the patient refuses a cesarean section, or in a situation where the gynecological situations where we face clinical dilemmas. And these sort of scenarios can help the students with critical thinking. They can find out what is the ethical problem in this and also come up with solutions based on the ethical principles. The ethical principles that we teach them is the justice, autonomy, non-maleficence, and beneficence. And this can help the students to understand the situation. We can also have debates and also have scenarios where they can come up with solutions to these problems. We also assign mentors who can, in a non-judgmental way, help them to become a practitioner later in their life who will follow ethical practice. And medico-legal aspect. All these bioethics is not only for protection of the patient, it also protects the provider. When we do ethical practice and in situations where there is a life-threatening situation and when we practice ethically, it also provides protection against liability when it is done in good faith and in line with ethical practice. So I think it is very important that we plan it in our daily practice, and it will help the patient to maintain their autonomy, dignity, and be to provide a patient-centric care for them. Thank you.
Thank you so much, Preeti. Absolutely right. Okay, the Obstetrics and Gynecological Society of India, many of us do not realize that OGSI was one of the first professional bodies that started in India, and this was in 1934. Many of us go there as speakers, as teachers, as participants, but however, many of us fail to realize that Dr. Ida Scudder was one of the founding members, and every time I go to Chennai, I'm amazed when I see her picture come up, and I think that how little we know about our own history and its participation. Having said that, Dr. Manisha, a senior professor in FMU, was a person who was the immediate past president. Dr. Rita will be taking it forward now. And so I asked Dr. Manisha a few words on collaborations with other professional bodies. So are we already doing it, and how? How can this contribute to a two-way advantage for CMC and others we interact with? And how can we increase our engagement with other professional bodies in future? Dr. Manish.
Thank you, ma'am, for the question. So, yeah, it's very heartening to see that Dr. Ida Scudder was one of the founding members of Vellore Obs and Gynae Society. And as I think Jessie ma'am or Lakshmi ma'am, one of them put on the slides that they attended the conference in Madras in 1977. So all these things actually, the origins of Vellore Obs and Gynae Society and all of my seniors here, Dr. Jessie, Dr. Rachel, Dr. Aruna, Dr. Lakshmi, Dr. Ruby, I think in various forms have been involved with the working of the Vellore Obs and Gynae Society in various roles. And actually we got inspiration from them to be able to continue the thing of, being a part of the Vellore Obs and Gynae Society. And as a member of the Vellore Obs and Gynae Society, we have a huge role to play, and Dr. Lakshmi was correctly pointing out that we kind of act as a bridge between CNC and the private sectors and the other collaborators. And I think that is very important for us to be relevant to this. I remember one saying by Dr. Johnny who said that relevance without excellence is flat, but excellence without relevance is flat. So we not only need to be excellent, we need to be relevant as well. And to be relevant, I think we need to engage ourselves with the society and those professionals around us. So I think that is the very important thing. And as far as we have been doing quite a bit, in fact, for training doctors for national health mission, doctors who are based the gynecology department for cervical cancer screening, and also we are being on different, different roles we are being involved. But I think we need to take it to the next level as well. And as far as our teachers and all are concerned, I remember the master classes that you all went to, ma'am, Lakshmi ma'am, Aruna ma'am, and we did, go to different places, different colleges, where we got to interact with different kinds of students and not only us. So that also makes a big impact, because now more and more people are being aware of practice of evidence-based medicine. It's slowly moving towards that, And we were the only ones, but now everybody else is asking about it. And when you talk about evidence for practice of medicine, they actually look at evidence from high volume centers like us. So we are, as Digiman said, we are supposed to set the benchmark rather than looking at guidelines from, let's say, ACOG or RCOG or NICE or anything like that, because there is so less data, there is so less clinical guidelines from the LMIC setting, and I think we have a major role to play. So it is of paramount importance that we engage ourselves as an institution to be able to be not only excellent in our work but also relevant. Thank you so much.
Thank you, Manisha. So, Dr. Rita, who's worked in a mission hospital, who took her sabbatical to go there for a short while, I'm going to ask her about outreach and missions. It's becoming very difficult for us to send raw, fresh postgraduates, but we need to keep the engagement going. So, CMC emphasizes on holistic care, and towards this sensitization, mission hospital postings are mandatory for UG students. For postgraduates, and especially now the shift has gone to our junior consultants. Is there a role in today's world for mission hospitals? How do we foster that attitude, continue to foster it among our students, and how can we as an institution contribute to missions? Dr. Rita.
Ma'am, thank you for the question that you have given to me, which is very passion for me to be in the mission. The first question is there any role of mission hospital in today's world? Going back, like Dr. Ida Scudder took this model and she went to the roadside to look for the patients. She didn't expect the patient to come to her, but she went out. So like that, mission hospitals are also small peripheral units of CMC established many years back. So, in my opinion, if the mission hospital are centered their practice around ethical and compassionate and affordable care, even this today's world, it makes a very important impact, even though there are many hospitals are around. So I just want to highlight two incidents that I happened when I was in sabbatical 2 years back. One was a patient, a middle-aged woman who was diagnosed with the HIV, and she also had an abnormal bleeding. So she went and knocked all the gates of the hospital for about 3 to 5 years in and around that town, but nobody was willing to take her and help her, and she was needing a surgery which nobody was willing to give her. So finally, she landed up in Mission Hospital, and with necessary precaution that we have helped, and seeing that there are many other patients also came along, and without any discrimination, all of them have taken the treatment. So what the other hospitals and the organization could not afford at that, even in the recent years, the mission hospital was able to do that. The other incident that I can quote is when a 33-year-old woman, she was a case of primary amenorrhea, and she was labeled with a wrong diagnosis for more than 2 decades. She was 33 years by then. So by a thorough history and clinical examination, she was diagnosed with suspected to have androgen insensitivity syndrome, and it was confirmed by a relevant investigation within 3 weeks of her visit to a mission hospital. So that emphasized the affordable care, and we here in the during the training period, we give importance to the clinical examination and the history, and I really thank all my teachers who are here, who emphasize that affordable care, and we should continue to teach our students to give, and when they go into mission hospital, they can practice this and fulfill the affordable and compassionate care. So I feel mission hospitals are still relevant, and there are many beneficiaries of this mission hospital which are in the periphery. The second question that you asked is how to foster the attitude of mission in our UGs and PGs. I know it is very difficult at this current scenario, because many the students lose passion to work in a mission hospital. But I can remember there are good bunch of the recent graduates who are working, still working, and choose to work in a periphery where in a very remote places. I can mention few people because they are all source of encouragement for the younger generation. Dr. Evelina, she is working in a remote tribal village, and Dr. Nandini, she is working in a rural unit of JIPMER in Pondicherry. Dr. Parashuta Rao, who is working in a mission hospital in Assam. Dr. Christabel, Dr. Catherine, Dr. Reena are working in various mission hospital, and the list goes on. So we have to keep teaching and giving that exposure to the students, UG and PG students, and whoever is willing, whoever is passionate, they will be able to take it and take it forward. So the last question is how, as an institution and as a department, will be able to nurture this culture. So there is a great challenge for the doctors who work in a mission hospital, and I myself had that challenges to face. So we have to expose the students to the challenge and encourage them to face the challenges. And as an institution, as a CMC also will help all the stakeholders of the hospital to align themselves to the mission, medical mission. So that will be very, very helpful for the students to face the challenges in the mission hospital.
Thank you very much, Dr. Rita. Just two more questions to go. Dr. Anne, who works in our community department and who does community obstetrics. So the question to Dr. Anne is, what are our rural programs? How does it help to train our students and sensitize the caregivers? Dr. Anne.
I'm part of a larger department called the Department of Community Medicine, but I am also faculty of the Obstetrics and Gynaecology department. And the Department of Community Medicine has been providing healthcare to rural areas in our town for more than 50 years. And these areas include Kaniambadi, KV Kuppam, where RUSA is providing care, and even the urban slums in Vellore. Obs and gynae services are an integral part of the services that are provided by this department, though it is just a small spoke in the larger wheel, and many of these services and the structure has been started by Dr. Sulochana Abraham. And as this picture speaks 1,000 words, I think the numbers will tell you how relevant a community setting is still in this day and age. LCSU provides mainly primary health care. RUSA and CHAD, we provide secondary level healthcare. Antenatal clinics happen in the periphery, and it is usually run by community medicine registrars. High risk obstetric patients are then referred to be seen by a specialist in the base hospital. And we do ultrasound for patients who come to the hospital, both in the rural hospital as well as in the tribal area. So we cover a large area in Vellore. And it's not just obstetric services, we also provide breast and cervical cancer screening that is available to the patient. And this usually happens in camps in the villages. And if patients are detected to have screened positive, then they undergo colposcopy and even thermal ablation that can happen at their doorstep. So health, as we know, is a state of complete physical, mental, and social well-being. And it's not just the absence of disease. And so there are various determinants of health. And so we hope that we provide interns, postgraduates, both community medicine and family medicine, and an avenue to learn basic obstetric skills, but also to understand the person who seeks healthcare and to treat them as a whole, so that as doctors they will be caring and compassionate individuals. And as it is quoted very often, there is an India and there is a Bharat. So we in Tamil Nadu, we see a very high level of healthcare, but there are areas where the healthcare is not as good as it is here. And as a training institute, we are trying to equip our postgraduates, our interns, to be able to go and work in a place of need. And so they should be able to through the community health services, I hope that we will be able to show them what is possible in a low resource setup, high quality care at a low cost. Heritage is not always something that we receive. We have received much, but it's also something that we transfer on to the next generation. So I'd like to tell you a story about one of our patients who had come from a rural area called Palampet in Javadi. She was screened positive for HPV. And so once HPV is positive, the next step would be to do a colposcopy and then treat. So we were conducting the camp actually 100 meters from her house, but she would refuse to come to the school to do the colposcopy because as far as she was concerned, she did not have any symptoms. If there are no symptoms, why do you seek treatment? So the mindset of people is not always the same in all areas. To be able to identify what they think and to identify with them and teach them what is needed, what is health, and how we can provide for them is part of the role that we play. And we work in very close collaboration with the main hospital, so our referral systems are also in place. Thank you.
Thank you very much, Anne. So, Dr. Santosh, mental wellness, the big difficult word. Okay, everybody is stressed. The teachers are stressed. The students are stressed. Those associated with those who are stressed are also stressed at home and in our work environment. So the big question is, how do we manage the people? How do we manage the mental health and well-being of those who work with you? And how do we balance out the situation?
At the outset, I'd like to tell those viewers not to read anything into the fact that the one male on the stage is asked to talk about mental health. So please don't read anything into it. It is just purely by coincidence. Okay. So I don't think any of us has gone long without having one of these reactions that you see on the board. Either we go back after work angry, or we're withdrawn, or we can't sleep, or it affects our diet. So at any point in time, both trainees and faculty face various degrees of this. And so mental health is part of what we face. And I'm not saying that we as obstetricians are, elevated to a place where only we face it. But our patients, especially the obstetric point of view, come in with physiologically, they're well. And so they don't expect to get sick. And so when they get sick, there's a lot of pressure on us to ensure that they go back the way they came. And so that is the additional stress that we face. So I'll go through a few points that have helped me, and those who have guided me have given me some of these tips. And I don't expect everybody to follow all these tips, but some of them might be useful. Firstly, your own faith. It might be the Christian faith, or you might follow another faith. But you have to deeply believe that you are doing what you are doing because you are supposed to do it. And that helps, because at the end of the day, when you're exhausted, you haven't eaten, you haven't had a bath, you haven't brushed your teeth, and you're questioning what you're doing. When you know that you are part of a bigger purpose, what the institution was formed for and what you continue to do, that will definitely drive you. Many people come in with a faith that's already strong, and many of us build it up as we go, often through the valleys that we face, the difficulties that we face. And so I encourage both trainees and faculty to not be discouraged by those valleys, but be driven by those difficult situations to help strengthen your faith to face it the next time, and to impart that knowledge to those around you who might be going through that at the time. Secondly, you need a support system. For those of us who are faculty, it might be easier. We have spouses, we have family, we might be even more privileged to have extended family close at hand. But for trainees who come here, especially with the newer systems of entry, they've come here sometimes for the first time away from home. They've been led very sheltered lives. Everything has been from home. So they've come completely out of the blue to a new place, a new system. It can be difficult. And to cope with the stresses of work plus the unknown is very, very difficult. So I would encourage us to have support systems for them, mentoring systems. You have your guide and your thesis guide and thing, but it's often not somebody you want to see. At any point in time, they don't want to see you or you don't want to see them. We need mentors. I would suggest mentors outside the department, because otherwise you have mentors within the department. You tend to maybe, be worried about favoritism, or maybe the mentor becomes the provisional thesis guide, so to speak, or they try, there are worries about that, but we need to mentor them. We need students to be mentored and fostered in that care, to know that they have a support system within the institution. Thirdly, what are our expectations? We have to meet our expectations. Like Vaibhav very correctly said, there's always a feeling that we're not living up to the standard that was set maybe 10 or 20 or 30 or 40 years ago. But our expectations are different. Trainees are coming in completely fresh, not knowing how to start an IV line, not knowing how to communicate, and having done a lot of studies to get into it, but not knowing anything about the subject per se. So our expectations have to be tempered. I'm not saying our standards need to be lowered, but our expectations need to be tempered. At the end of their training, they may not be able to do every procedure that we may have been able to. But do they know enough to be able to safely do, or even more important, not do a procedure which might be dangerous? That should what we should be looked to doing. And if we have proper expectations, it reduces the pressure on them as well. And unless we give them that, then there's no point going and then telling, I expected you to have done this by now. If you haven't told them that, it doesn't happen, right? I'll give you an example that people often make fun of me for. When I go for a medical student clinic, and those of you who know me are already smiling, I can see that. So when I go to a clinic, if there are 20 students, there'll be 20 students on 20 chairs. There will be no extra chair for me to sit. So when I go in there, I look, I expect them to get up, and then I walk out and I go and get a chair and come. So every time I tell my friends, they say, why don't you tell them? So I said, no, I expect them after 2 or 3 clinics to bring the chair in. I'm still waiting for that chair to be brought in. Why don't I tell them? It's a little part of me that is worried that if I ask them, they might say no. So at this point, I'm still hoping that they see me and bring it. Yesterday, one of my junior faculty brought the chair in for me and said, that chair is for sir. And expected that hopefully in the future, they'll expect that chair will be brought by a student. I still have no expectation. So we have to peter our expectations to what is going on. But remember, with expectations come responsibilities. We correct our students, we inculcate discipline in them, they should learn from us. It's not an excuse for us to humiliate them or put them down, because discipline comes from learning from what you've seen. A lot of what I've learned is from people who have gone before me, people who I see with me now, who have taught me the right way to do things. It doesn't mean that my juniors will do it exactly the way that I want to. But if they don't immediately live to that expectations, immediately, taking it out on them is not going to improve that. I have to give them that power to be able to bring it to that stage. When there are unforeseen events or there are major problems, we need to debrief and find out what happened and actually find out how those who are involved are actually dealing with it. When a baby gets sick or baby dies, or even worse, maternal mortality, we deal with the scientific component of it, but nobody really goes beyond that and says those involved in it, are they coping with it? How have they dealt with it? Because some of these experiences stay with us for life, right? Your first mortality is often something that drives decision making for the rest of your life. So I would encourage us to have more support for these people and a formal way of doing it, right? The last two things I want to talk about is everybody should have interest outside of the department. I know it's good, and I know we've always taught about, especially in CMC, that work is a big part of what we do. But there are things outside of work. I'm not saying that you spend all your time not doing work, but find something that you like, right? I'm quite sure that most of my postgraduates and junior faculty, I don't know what they like outside of work. Some, they might play musical instruments, they might play sport. There are so many things that go on in CMT. There are photography groups, there are nature groups. Find what you do, and I'd encourage the institution to allow postgraduates to spend a little time doing that, and we can do that as a department. Maybe at entry, find out what they're interested, and continue to nurture them to do things outside of that. I like to end, and I'm sorry I've gone on for a while, that there is nothing wrong with any of us if our own support system can't work. To have, if we need formal help in people who are stressed about it, or people who are dealing with a background of mental health problems, or have the stress of work gets too much, there is nothing wrong with admitting that you need to have formal help. Somebody coming to an obstetrician is seeking formal help. Somebody going to a surgeon is seeking formal help. So in no way is somebody going to see a psychiatrist or a psychologist anything less than that. They also provide a service and they provide a job. So whether it's a registrar or a faculty member, if we are struggling with something, I don't think we should hesitate to seek that care, because sometimes it needs more than what we can provide as a community. So I'll end with this, and I thank you for your time.
Thank you, Dr. Santosh. So now we have all the solutions. The last question is, in an increasing digital milieu. How do we continue with the human touch and how does it help us in holistic healing? Dr. Kavita?
Thank you, ma'am. But a very difficult question to answer. Yeah. So I was thinking about it. The human touch, as we hold the hand of the patient in our OPD services during our ward rounds, we are trying to express ourselves, our whole compassion and care for them. That's the best that we can do to get their confidence and their attention. They'll open up to us, and they will also start feeling that we are treating them in a holistic way, like a person and not as an object for treatment. So in one of our studies done by Gigi ma'am, Baroness trial follow-up, we found that many of the young women who went from here after discharge, they were going through a lot of trouble at home, like domestic violence or suicides, homicides. So we actually should not be stopping with the treatment that we are offering in the hospital. I think in future we should look into how we can follow up them and offer some supportive care through social workers and family meetings, counseling sessions, and all. And many a time these patients comes with many problems, not only medical issues, they have a lot of financial issues. So in CMC, we are trying to support them, like by offering funds. That is the major way that we support them. We have a lot of funds available. And we are also offering them transport facilities, accommodation facilities, everything in-house, dietary, all the support system we are already providing for them. But something which is unique about this institution, I would say, that we can see all of you junior faculty should watch and give, it should be stored in your mind that this is the only institution where you see doctors accompanying sick patients, sitting by their side, praying for them, holding fellowship meetings where we remember sick patients and pray for them. So that is one of the cultures that we should cherish and we should hope to inculcate into the future generation.
Thank you very much, Dr. Kavita. I hope that we never forget the human touch. We never forget to hold the hands of our fellow workers and our patients and rest in the hands of God. So, as co workers, we should not become weary of doing good because this happens to us very often. Because in due time, you will reap what you sow. And that is a universal principle. Hold in faith, walk. In conclusion, we are not sure about the path our future will take for generations to come. I cannot stand here and say I'm confident I know what will happen 20 years from now. But our vision and mission based on God, I am absolutely sure will remain relevant, inspiring, and aligned to the needs and expectations for the ages to come. We need to revisit our vision and our mission regularly and communicate it clearly to our students and to our staff. This will help us to pass on the torch of life. At the time of India's independence, that was when the male, the what you call the men also joined into our medical college, and we are training leaders for the future. That was the emphasis of Dr. Ida Scudder, that native-grown doctors, Indian doctors for India, to bring us to build a strong India. Leadership and management will require very difficult decisions and at times unpopular decisions. But if your vision is what is leading you, then it will lead you to the right place and in the right direction. So, in Dr. Ida's words, we thank God for the way in which He has led us in the past, and we look forward to an even greater future. We need those who can take up the torch of life and carry on and make Vellore Medical College one of the outstanding medical institutions today, and shall I say, in the world. This depends upon you, our future students and our colleagues and our friends. Never forget that an institution is not a building, it is a people who live the mission, who carry the mission, and who walk the mission. And I hope each and every one of you will contribute, whether you continue to teach here or otherwise. and continue to contribute to the strength of this institution, which has been a part of your building days. Thank you, friends. Carry the torch of life. If any of you are interested, please read this first address of Dr. Ida Scudder to her graduates. She looked forward to a strong India and a strong Vellore. Thank you very much.